Hello and welcome to the Beat Cancer Answer, brought to you by BeatCancer.Org, the Center for Advancement in Cancer Education. We believe that 90% of all cancers could be eliminated through environmental and lifestyle choices alone, and science agrees. Unfortunately, most people don't know it, so we provide the education that can help you prevent, cope with, and beat cancer through diet, lifestyle, and other immune-boosting approaches. On every podcast, we will feature an expert who can teach us how to become part of that 90% who could prevent getting diagnosed with cancer. If you already have cancer, we have empowering information for you too. Over the past 35 years, we have helped thousands of cancer patients get back into the driver's seat when it comes to their personal journey of healing cancer and preventing future reoccurrence.
Listen now as BeatCancer.Org Educational Director Dr. Susan Silberstein interviews Dr. Philip Getson on the role of thermography in early detection and monitoring of breast disease.
Welcome, everyone. It's my pleasure to introduce our speaker for the evening. Dr. Philip Getson, D.O., is a board-certified family physician. He's been in practice since 1976 in New Jersey. Dr. Getson is an internationally recognized expert in the diagnosis and treatment of reflex sympathetic dystrophy, or complex regional pain syndrome, and has lectured extensively on that subject. He's also an expert in medical thermography, and that's why I've invited him to join us this evening. Dr. Getson is an assistant professor of medicine and neurology at Drexel University College of Medicine in Philadelphia, and of course we're very proud that he completed our training as a certified holistic cancer educator. Dr. Getson founded Thermographic Diagnostic Imaging back in the 1980s. He is a board-certified thermologist and has reviewed more than 25,000 thermographic studies. He has been certified by 4 thermographic boards. He has lectured nationally and internationally regarding thermographic testing and has authored several papers on the subject. He has recently completed a 3-year term as Vice President of the American Academy of Thermology, and he was Chairman of the committee responsible for formulating the protocols for breast thermography that have been accepted by the national and international thermographic communities. Today, he will be sharing with us some really valuable information about thermographic imaging. So thank you, Dr. Getson, for being with us tonight.
It is my pleasure to be with you, Susan, and my pleasure to be a participant in something so noteworthy and so terrific. You and I go back many, many years, and I'm glad to be a part of the wonderful things that you do.
And ditto. So let's make sure that our listeners understand exactly what is thermography and how does it differ from anatomic testing like mammography.
Okay, well, thermography comes from the Greek words which actually mean heat picture, and that's predominantly what we're doing. We're looking at the heat patterns that the body gives off, and we're taking a photographic image of this, both in black and white and in color. And we're able to take these images, be it of the breast or other areas of the body, and get certain data from them with the presumption that the human body is symmetrical, meaning that the left side of the individual and the right side of the individual should be, at least within reason, the same. So your left hand and your right hand should look the same. And in breast thermography, the left breast and the right breast should be the same. So we recognize that nobody is a completely mirror image, symmetrical human being, and we've built over the years certain protocols and certain parameters for measurement of that symmetry, and anything that falls out of that symmetry, whether it's by temperature or by configuration of blood vessels, is considered to be thermographically abnormal. The other thing to understand with thermography is that we're looking at the physiology of the breast and not the anatomy of the breast. Mammography, ultrasound, and MRI, the only 3 other tests that you can do in evaluating breast health, are anatomic tests. Anatomic tests look for lesions, they look for cysts, they look for tumors, they look for identifiable entities, whereas thermography looks at the physiology of the breast, meaning how does it work. And in medicine, it is always the case, not only in thermography, but in every facet of medicine, that physiology precedes anatomy. The physiology of the human body always changes before the anatomy, whether it's a blood test, whether it's an X-ray, whether it's a thermogram or a mammogram, lags behind. And in breast health, we have found out, based upon literature review that goes back quite a long time, that the thermographic images, the physiology of the breast, can change as much as 7 to 10 years before a mammogram will detect a breast cancer.
And that, of course, is going to be very predictive of breast disease then.
Correct.
So actually, how old is thermographic imaging, and what kind of research do we have that supports the use of thermographic imaging?
One of the great criticisms that I have when people don't know anything about thermography is they say, well, it must be new, and so it's
or
new,
there's no data,
information, and so on and
right.
so forth. So interestingly enough, thermography as a tool goes back to the Second World War. The United States government had it all to themselves, and they armed fighter jets with thermographic or heat sensing equipment that flew over missile silos in enemy territory. And when the missile silos came up hot, it was presumed that they were making bombs, and we would then bomb those missile silos. And when they came up cold, it was presumed that they weren't making bombs, and they passed over them. In 1957, the government released the concept of thermographic imaging for medical purposes. And the reason that 1957 is significant is that's 10 years before the first mammogram. So for those people who say that mammography's been around forever and thermography is new, it really is quite the opposite. Thermography actually precedes mammography by about a decade. And there are between 800 and 1,000 peer-reviewed literature articles worldwide on thermography that have happened in that time from 1957 to the present. So there's a wealth of information out there, and there's a track record that goes back, do my math, 54 years.
Well, we hear a lot about thermographic imaging, or at least I do, for breast health. What other areas of the body can be studied by thermography?
When you were kind enough to read the biography of me before we began this conversation, one of the things that you mentioned is that I spend a great deal of time evaluating patients with complex regional pain syndrome, which we used to call reflex sympathetic dystrophy. And without getting too far off base, that's a neurologic condition that is very similar in a lot of its presentations to fibromyalgia. In fact, there are those who in the medical literature believe that fibromyalgia is in fact a subsect of reflex sympathetic dystrophy. It is a malfunctioning of the sympathetic nervous system, and it is a diagnostic. It is a disease entity that you really can't image with conventional radiation, X-ray, MRIs, CAT scans, etc. It's a malfunctioning of the sensory nervous system, which means that electrodiagnostic testing doesn't give you answers, and there's no laboratory test for you. Interestingly enough, in a disease that probably afflicts between 4 and 10 million people in this country, thermography will beautifully image reflex sympathetic dystrophy, and in fact does it better than anything else. And so I tell people when I talk about that, when I wear that hat, so to speak, that thermographic imaging is the diagnostic tool for complex regional pain syndrome. The third area...
So when they tell you it's all in your head, you can prove that it's not.
Well, you know, a picture's worth 1,000 words, to use that old cliche, and so many times in the last 20 or 25 years, I've brought people in, and they come in with this thing saying this is a psychiatric problem, and it's in your head, and you take pictures, and you've got one limb that's 3 or 4 centigrade degrees cooler than the other, and I will show it to people, and I'll say, well, if it's in your head, explain to me how this picture looks like this. And the answer is you can't. I mean, it's a real disease, and you're right. A lot of people say it's in your head. It's psychological. There's nothing wrong with you. You're involved in a lawsuit. You're trying to make money, whatever it happens to be. But the realization is it's a very real problem, and we now have a diagnostic tool that will image it and give you concrete evidence that this, in fact, is real and not imaginary. In the course of doing thermography, which I've been doing for over 30 years, we began looking at the thyroid gland because it came to pass that we recognized that there are so many people out there that have symptoms of thyroid dysfunction and normal thyroid tests. The conventional thyroid tests, T3, T4, and TSH, are really woefully inept at diagnosing thyroid disease. And so someone comes in with clear-cut symptoms that suggest that their thyroid is malfunctioning, and they have normal tests. And as a physician, you have kind of a problem there, because you really can't treat somebody for a problem when the testing is normal. You put yourself in a medical legal situation which is dicey at best. And now we have a physiologic test that says, well, while the numbers may be normal, the physiology of the thyroid gland isn't, and it allows us a greater latitude to be able to treat people who have symptomatology consistent with that problem. Interestingly enough, when we started imaging thyroids, we started imaging faces as well, and we began to find just an overwhelming amount of dental problems, dental inflammation, dental infection, and a correlation between dental problems and malfunctioning thyroids, and in fact dental problems in breast cancer. But we found out that almost, I would say probably 8 out of 10 people where I find a dental abnormality, the person will come back and say that was an area where they either had a root canal or a crown, which left them trapped in inflammation or infection and created a problem that's causing a heat. And when you get them to biological dentists, which we try to do, and you correct that dental problem, it's amazing. Some of the sinuses clear up, some of the thyroid malfunctions disappear, and in fact, sometimes breast health even gets better.
Right. And of course, the thyroid is also relevant in breast health. So it all goes together. Are there any specific cancers or cancer promoting properties, tendencies that the thermographic imaging can pick?
Well, as a physiologic test, we don't see tumors. We don't see cancers. What we see is the physiologic abnormality of the breast predominantly that leads one to believe that either there is a problem that may be cancer, or that they are physiologically heading on a path where if they don't...
Well, I'm talking about the path. Are there other areas of the body where we can determine through thermography that there is a precancerous pathway?
Perhaps in the thyroid gland, but other than that, no.
Okay. Because that question often comes up. All right. Now, let's get into a little more detail about how thermographic imaging can detect potential breast cancer in terms of accuracy and in terms of timing as compared with mammograms.
Okay. Understand that mammograms will see some cancers when they are big enough to see. And cancer, as you know, because you deal with cancer and have for all these years, cancer, at least in my estimation, is the only disease in this country that we wait till you get it and then treat it, and we don't really look to prevent it.
Yeah, well, we're trying, aren't we? We're trying to prevent it.
But, it's interesting.
But we're just doing early detection.
Right. I mean, but it's an early detection of cancer and not an early detection of signs that suggest that it's time to change diet and lifestyle so that you don't get the cancer. Mom is a diabetic. You're doing blood sugars when you're a teenager just to make sure you're not heading in that pathway. And when the blood sugar numbers start to go up, you change your diet and you change your lifestyle. But we, in this Western civilization, wait for breast cancer, say, okay, you got it. Now that you got it, we're going to go ahead and treat it. Well, thermography is a little bit different. Thermography looks at the physiology and looks at the vascular configurations and the heat patterns and says, you're doing something wrong. It's time to make changes. So because it's physiologic, it's very, very sensitive and not as specific as perhaps an anatomic test, one of the 3 that I mentioned earlier. So we can give you a generalized area of concern. It may be the lower outer quadrant of a breast, for example, but I can't say to you that it's 1 centimeter from the nipple because it's not an anatomic study. But because it's physiologic, we can find changes in the breast that if changes occur in the diet and lifestyle, I've seen many, many women where the physiology changes, and these women never really get to a point where they have concerns for breast cancer because they've made adjustments in their life to forestall it.
Beautiful. And I think that you mentioned a window of about 7 or 8 years in terms of picking up a tendency towards breast cancer that much earlier than a mammogram, which you need, I don't know, millions or trillions of cells before our anatomical tests are going to pick up a malignancy. But
you're absolutely
we can,
correct.
right?
The numbers are astounding as to how cancer, I mean, I'll give you this quick thing. At 90 days, we have 2 cancer cells in an area. At 7 years, we have 268 million.
Mm-hmm. So somewhere in there, somewhere at 90 days or at a year or even 2 years, we only have a couple of hundred cells at most that a normal immune system could handle, or an optimal immune system could handle.
Even at 3 years, there's less than 1,000.
Mm-hmm. Well, that's the good news, right?
That's the good. For those listening, I'll tell you one brief story. I had a woman come in, and we did the thermogram, and I looked at the pictures, and they were horribly asymmetrical. The heat pattern on one side was much greater than the other. The vascular patterns on one side were much more intense and worrisome than the other. And I talked to her on the phone, and I said, this is heading in the wrong direction. You have thermographic evidence of breast disease. And she said, what can I do? And we talked about diet and lifestyle alterations. And I know how important diet is to you. And I've sat in some of the lectures and the courses you mentioned earlier, and how so important it is to clean up the diet. So this woman went on a program where for 6 months, she really had a pristine diet. I mean, she ate real food and stayed away from the boxes and the GMOs and the artificial sweeteners and all those things. And she came back 6 months later, and I took the thermographic images of her, and I looked at it, and it took me about 5 minutes to realize that it was the same woman, because the changes in the breast were so significant, so dramatic. And so we had a conversation, and she said, this is great, I'm great. And a year later she came back, and it was great. And a year later she came back, and it was horrible. And I said to her, my God, what did you do? And there was a 30-second pause. She said, well, I kind of got tired of eating that way, so I went back to eating the way I used to eat. And she said, so don't lecture me. I'll be back in 3 months. And 3 months later, she came back, and it had reversed itself back. And she said, you don't ever have to worry about me eating wrong again, because I learned my lesson.
Oh, that's beautiful. And so that shows that women can be very proactive in their breast health concerns with a tool like thermography.
That's our goal. Our goal is to help women understand that their diet may be an issue. We advocate against underwire bras, both for the compression of the lymphatic system and also for the EMFs that the metal can cause in a metal underwire bra. We advocate for breast health. And all those things that make people healthy, vitamin D and sunlight and proper eating and exercise and weight reduction, because you do all of these things, you do them to get healthy. It's not just for breast health. I mean, it's for generalized overall health. And the breast health is what we're looking at and a part of it. And what thermography allows women to do, as it was in the example that I just gave you, is to actually see that they're getting healthier. In addition to feeling better, they can actually see the changes that occur when they make alterations in their diet and lifestyle.
That's wonderful. And of course, we shouldn't leave men out, because men can get breast cancer too. And,
you're absolutely correct. And I will tell you that in 40 years of practice, touch wood, I do it every day. I've never seen a male breast cancer. I've read about it, but I've been very fortunate.
Mm-hmm. Well, I guess the men have been fortunate too. There are many reasons women and men get breast cancer. We know that radiation exposure is a known risk factor for breast cancer, and that includes radiation conferred by mammograms. How do you see mammograms actually potentially increasing risk for either developing breast cancer or for breast cancer spread?
Okay, so in 2005, the National Toxicology Program of the United States of America classified X-rays as known human carcinogens. And so they basically were saying at that point in time that we are using a diagnostic tool that emits radiation to find out if someone has a disease that is caused by radiation, which, of course, goes beyond illogical. The medical literature suggests that the first reference to the compression part occurred in 1928, which is almost 40 years before the mammographic equipment, and a physician in a journal called Radiology, which, as you know, is the journal of the X-ray docs, the docs that read mammograms, warned physicians to be careful handling cancerous breast because he didn't want them to accidentally disseminate the cells.
So the compression that the mammograms.
Correct.
Oh boy.
Correct. And there's just study after study that talks about the evil of compression, the evil of radiation. And I think the most noteworthy one came from the Nordic Cochrane Group. The Cochrane Group works out of the country of Norway, hence the term Nordic Cochrane. And they are an outcomes group. They take medical data and they categorize it, analyze it, and give it back to the people who want to see it based upon research studies that have been done all over the world. And they very rarely offer opinions. But in 2013, they said that it no longer seemed reasonable to attend for breast cancer screening, which was mammography. And they further said by avoiding going to mammograms, a woman lowers her risk of getting breast cancer. So it was unheralded that they came out with this report that said, in essence, based upon the information that we have, mammography really is a carcinogen as opposed to something diagnosing a disease. And this was followed up shortly thereafter by a couple of studies, one in the New England Journal of Medicine and another in the British Medical Journal, where they looked at cancer outcomes from mammography. And they came to the conclusion, and I love this statistic, if 2,000 women had an annual mammogram for 10 years, or 20,000 mammograms, the number of women whose lives would be saved by mammography out of that 2,000 was one. Not 1,000 or 100, one. And this is based upon studies that lasted between 25 and 30 years. And one of the conclusions from one of the researchers, who was an MD gynecologist, was that few breast cancers were destined to kill no matter what we do. Because so many breast cancers really are not life-threatening. And yet we are radiating them, we are excising them surgically, we are doing radical procedures, and we're giving people all those cancer-causing and toxic chemicals to get rid of something that really wouldn't shorten a woman's lifestyle and alter her outcomes if we just left them alone. So we have a diagnostic tool that is perpetuating cancer, that has a tremendous amount of false positives, and is looking at breast cancers, the small innocuous breast cancers, as being life-threatening, leading to all the physical trauma of radiation surgery and chemotherapy.
Not to mention the emotional trauma.
Thank you. You took the words out of my mouth, because it's something that we
Sorry, I'll keep quiet.
But absolutely. I mean, how many women will listen to the things that you and I talk about where they have a mammogram and one of two things happens. They say, you need to come back and get more studies, or you need to come back in 3 months and do it again, or you need to come back because we're really not sure what that is. And so they stay awake basically for the next 90 or 180 days worrying about what it is. Or they're told that they have a cancer, that really would never have been a problem. And then they have to go through all the litany of this, and then they sit and wonder for the rest of their lives whether the doctors got it all.
I think I saw a statistic somewhere in the New England Journal of Medicine that there's over 1 million women who are overdiagnosed with breast cancer over the last few decades.
In the British Medical Journal, you are correct.
Oh, it was in the British Medical Journal?
Yep, it was in the British Medical Journal, and they said it was based upon a Canadian study, and they said that of all the women were diagnosed with breast cancer based upon mammography, in the course of this 20-year study, 50% of them were overdiagnosed and overtreated.
Yeah, that's the problem. It's not just telling them they have cancer. They were treated, which some of the treatments could actually make the situation worse, like the radiation and the immunosuppressive chemotherapy. So, there's unnecessary, there are false positives They're unnecessary biopsies. They're unnecessary lumpectomies, probably unnecessary mastectomies as well.
Correct. And I will tell you that the head of the American Cancer Society 3 years ago asked for a reclassification of DCIS because he said DCIS, and I have women come in who had bilateral mastectomies for DCIS, and the head of the American Cancer Society said, we can't call this DCIS, the C being cancer, because it's not cancer.
And yeah, and that, right, that's ductal carcinoma in situ or in situ.
Correct.
So that basically, because it's not invasive, right?
It's non-invasive.
Right.
And doctors are telling people, well, we should do this and do that because it may become cancer. Well, it's not cancer, so leave it alone.
I've worked with patients who were told, terrified, because they were told they had breast cancer, and I said, well, did they tell you anything else? Yeah, it's DCIS stage 0. So they want me to have a double mastectomy. Well, you're a physician. I cannot give any medical advice, but my eyebrow raised so high that I think she heard it over the phone, because that's almost immoral in my mind.
And as a physician, I'll take the word almost out of there.
Anything you can tell us about the value of breast MRI and ultrasound testing as another option to mammograms, and how that might fit with thermographic imaging?
Certainly. When I get an abnormal thermogram, and I don't have a reason for it, meaning that there was no trauma to the breast or something that is identified as being an etiology for asymmetry, when I get an abnormal thermogram, I will generally, if it's a localized area, try and offer the women the opportunity to have an ultrasound done. Ultrasounds are innocuous. They're covered by most insurers. They are sound waves. There's no radiation. There's no compression. And often if something is of size, we can get some information from an ultrasound. And a negative ultrasound may not be 100% peace
negative
of mind
meaning
giving.
Good news, right?
But it does help give some peace of mind.
Right.
MRIs of the breast are very difficult to obtain simply for insurance reasons. I can tell you that Horizon Blue Cross and Blue Shield of New Jersey will not authorize an MRI. Here's one for your listeners. Horizon Blue Cross and Blue Shield of MRI of New Jersey will only authorize an MRI of the breast if the woman has had a biopsy that is malignant.
Oh, gosh.
And I said to the doctor, when I went to medical school, and granted it was a long time ago, we used to do diagnostic testing to prevent invasion, to prevent unnecessary surgeries. Why would I do an MRI if I already knew that the woman had breast cancer? Yeah. And his answer to me was, don't shoot the messenger. I'm only relaying to you what their policy is. So the problem with MRIs really is they're very sensitive. They are fairly accurate. They are relatively innocuous. There is an injection of a gadolinium dye, which is excreted in the urine within 24 hours. And while there are medical reports of side effects from gadolinium, I've never seen one. And the objection from some of the medical communities is there's too many false positives, but they don't talk about the false positives in mammography when they tell you that. And it's good. Now, an MRI will not show you microcalcifications, and I guess we should spend a minute on microcalcifications, which
Great, yes.
I don't even know how to describe microcalcifications. Microcalcifications are only seen on mammograms. They're not seen on ultrasounds or MRIs. And microcalcifications, by their very definition, are micro. They're small. They're pencil points. And they give radiologists cause for worry, and breast surgeons cause for worry, and gynecologists cause for worry. And I will tell you from my experience that about 85% of all biopsied microcalcifications are benign. And of the remaining 15%, about 14% of that 15% are biopsied cancers that would never cause an alteration in a woman's life, would not shorten her life, and would not cause any side effects. So for all the microcalcifications that I've been privy to in all these years, about 1% of them would really be a problem. But the radiologist say, oh, you got microcalcification, you need a biopsy, you got to do this, you got to do that. And again, we're back in that conventional medicine milieu, which is fear-based, and it says you got to do something because you got cancer. Well, you and I both know we got cancer walking around talking here tonight. We have cancer cells in our body, but our immune system is doing a wonderful job combating them.
Right. So that's our bottom line. We all have cancer cells, but let's make sure that our immune system is optimized in as many different ways as a patient would be willing to consider. And you may never have a problem with those oddball cells that are floating around. I'm glad that you brought that up because yes, patients are terrified about that as they are about DCIS, which I think might be quite similar to microcalcifications. Certainly in terms of how dangerous
the fear-based nature of them.
Yeah.
Yes, in that respect they are.
Yeah. So I'm going to want to open the lines up so that people can ask you questions. Before we do, I don't want to forget to let people know that there's some excellent information on thermographic imaging at Dr. Getson's website. That's the TDINJ.com. Is that correct?
That's correct.
TDINJ.com. That's for New Jersey.com. And that, why don't you also let our listeners know how you can be reached if they have additional questions or if they wish to refer you a patient?
Well, there's a couple of ways. There is a link on the website to our email address, which is TDI for Thermographic Diagnostic Imaging, TDI@Comcast.net. And also on the website, the phone number, which is 856-596-5834. And they will get Leisha on the phone, who's been doing this for about 16 years and answers all the technician and many of the questions that people have when they don't have, when it's really a technical medical question, then I'm available to answer those questions. And I read all the thermograms, as you know. These are not outsourced to somebody in another state or another city or another country. So everything comes through us. And this way, you know who's reading them, and you have the availability to talk to the people that are taking the images and the people that are reading the images, which we think is the right way to do this.
That's good. Now, one last question that I have, and then I'll give other people a chance. Let's talk about insurance coverage and costs out of pocket if insurance does not cover.
We do not participate directly in insurance. The fee for a breast thermogram is $300. That includes the performance of the study. We send the actual study to the patient with a report. We send copies of the report to any healthcare practitioner that they wish. It also includes the opportunity for a phone conference directly with me after office hours so we can go over the images and they can understand what they are seeing and what the ramifications of those images are, whether they are normal or abnormal. We charge $125 for a thyroid and dental study, and if you combine the two, we take $25 off of that. Same answer. You know, the information is there, the images are sent, the reports are sent, and the availability is there. As far as what we call a full body study, which we do for neuromuscular problems, only reflex sympathetic dystrophy, they're not general screenings. That fee is $475, and again, same answer. There are coupons in some of the magazines. There's a senior discount that we offer to individuals over 65. If you need to have a repeat, we also factor if we have to do one in short order, 3 months or 6 months, we discount them as well. So
I mean, that's really very reasonable. When you think about it, what it is about $2,000 for an MRI or more?
We tried to do that, and I will tell you, we haven't changed that fee in about 5 or 6 years. And the other thing is, and this is the really good news, 5 or 6 years ago, we were getting a smattering of people that were getting reimbursed by submitting it to the insurer. And now we're getting about 33% of people are getting anywhere from $50 to $240 of that $300 back by submitting it to their private health insurers. which tells me
insurance may reimburse the patient. You don't do direct billing, but there are companies that are reimbursing patients. At least
correct. And actually, Horizon Blue Cross that won't pay for MRIs is actually reimbursing patients up to 80% of the price of a thermogram, more and more. And I think they're starting to see that more and more women are looking at this as a way to go. We're seeing more and more individuals that are getting the reimbursement, and I think it's terrific.
Well, I do too. It's supply and demand, or if the consumers are going to demand it, then the insurance companies, it's really smart for them because it's going to affect their bottom line for sure.
As my father used to say, from your mouth to God's ears.
Thank you so much for joining us on the Beat Cancer Answer. If you learned just one thing today about how to prevent, cope with, or beat cancer, then we have succeeded in our mission. For more information or assistance, visit our website at BeatCancer.Org. Remember to sign up for our educational email series and get your free gift. Join in the conversation on Facebook, Twitter, or Google+, where you can meet others who think just like you. We appreciate all of your feedback and love your suggestions. Please also remember to rate us on iTunes. Your positive ratings help us to get discovered so we can save more lives. Thank you again for listening, and best wishes for good health from all of us at BeatCancer.Org.